Welcome to Prescribed by Dr. Nathan Goodyear, where integrative oncology meets holistic healing. This podcast is your home for the latest in innovation, exploration, and elevation in all areas of integrative oncology, medicine, health, wellness, and beyond. Join me and a host of other innovators as we go from practicing to prescribing. Your daily dose of wellness begins now.
Repurposed medications in oncology. Pharmacy shrill versus pharmacy denier. I'm noticing something very interesting, both in the public arena as well as in the medical and scientific field. It appears that we have two camps of repurposed medications. See, there's the conventional medical side where there are certain repurposed medications that are acceptable and others that are not. And then there's the natural integrative side where there's equally its own branch of repurposed medications and others that are not acceptable. And those two camps don't accept the other two camps accepted repurposed medications. It kind of goes back to, two kids on the playground just yelling insults at each other. Now, what am I talking about, Dr. Goodyear, right? Well, I'm talking about Ozempic. Now, on the conventional side, we have Ozempic and GLP-1 agonists. And then on the integrative or non-conventional side, we have Ivermectin, mebendazole, Artesunate, Artemisinin, metformin. Many there that are embraced, loved, and the conventional side refuses to acknowledge them. Flip that. On the more integrative side, looking at things like the GLP-1 agonists and others such as Kineret, Actemra, Pirfenidone, thalidomide, they go, no. Cross symbol, silver bullet, no. And what really brought this to my attention, it hit me this morning, actually shot a reel, then went and was with 3 patients undergoing intratumoral procedures down here in San Jose de Cabo. There was a ex-post from somebody. They were commenting on a post from a doctor who was celebrating the benefit of GLP-1 agonists in reducing the incidence of breast cancer. That's significant, almost 30%. And the comment by the nurse practitioner of that celebratory ex-post was another pharma shrill. The implication is they're big pharma supporter. See, pharma shrill is big pharma supporter. Now, I'm not a fan when anything loses focus on the patient. That's big pharma, that's big medical device, that's hospital, that's government, that's bureaucracy, any of it. So, can there be good pharma? There can. Can there be big bad pharma? Pharma shrill, of course. But the comment here was that there was good research presented at ASCO. Of course, the paper hasn't been published yet, but the immediate reaction was pharma shrill. Well, let me flip that script. I mentioned Ivermectin. Immediately, over half of the doctors out there will turn off their hearing. They will not listen. They will not accept. They will not even acknowledge the volume of preclinical evidence with Ivermectin as it relates to anti-cancer repurposing. Even if I say, look, there's limitations in here in that we really have no clinical data. We need to translate from preclinical to clinical. They won't even go there. I celebrated the McCullough's group and their 6-month survey of patients taking both Ivermectin and mebendazole, how this was really the first foray into the clinical aspect of Ivermectin and mebendazole as repurposed medications in oncology. But I also was very critical of a lot of the data was in there. But that doesn't mean critical can't celebrate. So what I want to do here is I want you to understand that when we talk about repurposed medications, integrative medicine is what threads the line between camps. What does the evidence show? The evidence says we need to make whole the individual, make whole the treatment strategy. And that's really what integrative is. make well. And so if we can use a medication that's been proven safe, repurpose it in a process where we have cancer, changing demographics of cancer, where cancer is becoming more prevalent in obese, it's becoming earlier, more aggressive, progressive disease. The CDC and British Medical Journal that I've documented everywhere, British Medical Journal 2023 showing earlier, more aggressive cancer types, and the CDC showing that the age-adjusted mortality rates in obesity-associated cancers has tripled from 1999 to 2020. One generation. One. But yet, people can't look at the changing demographics of cancer without putting on their blinders and stepping into the camp that they're in. I'm not in any camp. That's why I'm not afraid to call out the unholy trinity of surgery, chemo, and radiation. And I'm also not afraid to call out something on the natural integrative side. For example, saying that, with the ivermectin, mebendazole, we have to understand that is a 6-month survey reliant on patients filling an online survey. It's very weak evidence. In fact, 5% roughly of those patients were in a clinical trial, which means they do no other treatment, yet they did the other treatment. So that right there shows at least 5% there's a dishonesty in hurting. So what I want to do is I want to try to approach this not in a one disease, one drug, one treatment, but say, well, let's look at the evidence here of a little bit of the GLP-1s on one side and ivermectin, mebendazole, and artesunate on the other, and just look and see what it shows. Because when we talk about Ozempic, we have to understand, and the GLP-1 agonists, we have to understand there's side effects there. There's not a question. I've actually written a PR piece on this about a couple of years ago, and it was regarding the side effect profile associated with the GLP-1 agonists. So I'm getting to my notes here, so forgive me. But up to 40% of the total weight loss in individuals using the GLP-1 agonists, because understand it's FDA approved for type 2 diabetes first, now obesity, massive muscle loss. 40% total weight loss was lean body mass. That's muscle loss. Now, this could be because of reduced protein and calorie intake, because GLP-1 agonists will reduce appetite and will reduce protein anabolic intake associated with that. You get a negative energy balance, which is catabolic. You have reduced exercise capacity because of reduced energy, because of induced calorie intake. Reduced mechanical loading, that's because of the reduced activity. We have a little bit of a imbalance where there's more catabolic breakdown versus anabolic building up. Now, when you look at the older individuals undergoing this, it's a little bit of a different scenario, especially if there's pre-existing sarcopenia. I understand with age, we actually have an age-adjusted decrease, or age-adjusted increase in anabolic resistance, decrease in anabolic growth. So in an older individual that's more prone to sarcopenia, muscle loss, that's not built into their strategy or built in pre-aging this muscle building capacity, because there's definitely some muscle memory there. Sarcopenia is, I don't want to say inevitable, but it's kind of a predestination, if you will. I don't believe in predestination, but they're predestined to that because they've not built up that muscle. Also, there's that age-related anabolic resistance that I talked about. There's more inactivity with aging and inadequate protein intake because of dysbiosis, gut issues, as well as poor caloric intake and balance as people age. And of course, there's vision loss with a non-arteritic anterior ischemic optic neuropathy. Goodness gracious, who came up with the name of that disease? But it's NAION, non-arteritic anterior ischemic optic neuropathy. Now, we have to understand the GLP-1 agonists are used in the treatment of type 2 diabetes, now obesity. Understand that NAION is already more common versus the general population in patients that are diabetic, obese, sleep apnea, which you see in the obese, cardiovascular disease, hypertension, cardiovascular disease are more common in type 2 diabetes and obese. So what you have here is a population where there's already a selection for an increase in the non-arteritic anterior ischemic optic neuropathy. Say that once, let alone 3 times. So what we have here is patient population already at risk. And when you add in the GLP-1 agonist, it goes from a fourfold higher risk in just the diabetes to a 7-fold higher risk in somebody using the GLP-1 agonist. So it is real of an increased risk, but we have to recognize that if we're talking about sarcopenia, maybe population selection with the use of GLP-1 agonists, we have to talk about, okay, well, if we implement resistance training, exercise, appropriate nutrition, can we counter this? It's not just a drug to bypass any and all other therapeutic strategies to help people achieve weight. Counter that with some kind of bariatric surgery where what you end up with there is disrupting the gastrointestinal system, disrupting the actual normal nutrient sensing, and then you have to supplement that for the rest of your life. So we have to recognize there is some safety and some side effect issues there. However, in being approved for type 2 diabetes and obesity, the GLP-1 agonists, they have been shown to be safe overall, not without risk. Nobody denies that. Now, the question is, can we work with that same mechanism of action that GLP provides through the metabolic, through the hormone, through the microbiomic, through the immunologic? Can we work in that same area without using GLP-1 agonists? Well, the question is, what about the individual, the risk of the individual? Are they severely obese, type 2 diabetic, major cardiovascular risk, stage 4 cancer? There may be time on the side of that individual and of the medical team to say, well, let's just use something that's more natural, though there's nobody that wants to be more natural than myself. They may have a necessity of time so that GLP-1 agonist therapeutic can come in while they're working naturally, working nutrition, working resistance training, etc. So I want to go through just a little bit of the data here that was presented at the ASCO, American Society of Clinical Oncology 2026. But first, I want you to understand that there was data already pre-existing. See, in 2024, check out the show notes for the supporting evidence. There was a journal article published in Journal of American Medical Association, glucagon-like peptide 1 receptor agonist in 13 obesity-associated cancers in patients with type 2 diabetes. And what they were looking at here is a GLP-1 receptor agonist, Ozempic and Wegovy, as looking at them as a repurposed medication in reducing the risk of obesity-associated cancers in patients who were type 2 diabetics. It was a retrospective cohort. And what they found is that the implementation of the GLP-1 agonist here actually lowered the risk of 10 out of 13 obesity-associated cancers. 10 out of 13. This was compared to insulin and metformin. So that means that these patients that were receiving insulin for their type 2 diabetes, in turn had a GLP-1 agonist. They actually had better reduction in cancer risk in the GLP-1 agonist compared to insulin. Now, there was one obesity-associated cancer where actually metformin outperformed the GLP-1 agonist, and that was in renal cell carcinoma. And this study was a study of 1.6 million patients, no small number, and it followed these patients from 2005 to 2018. So a significant follow in that time. The reduction here was in esophageal, liver, gallbladder, pancreatic, colorectal, kidney, endometrial, ovarian, meningioma, and multiple myeloma. So that was preceding all the uproar coming out of ASCO 2026, just a couple weeks ago. So let me go through very quickly because people advocating that, celebrating the benefits of Ozempic per the evidence. This was, of course, just abstract. So we need to see those studies come out and carve them up. But I think the phrase of big pharma shrill is big bias blowout. Big bias blowout. So looking at metastatic progression study, this was the most publicized. Again, an abstract. It was at the Cleveland Clinic. Over 12,000 patients analyzed. They compared the GLP-1 agonists versus DPP-4 inhibitors, which basically DPP-4 actually will break down the incretins, and here it inhibits and allows those incretins to stay elevated. These are released when we eat. What they found in this abstract was reduced progression to stage 4 disease. So looking at stage 1, stage 2, where there was, and even stage 3, where there's no evidence of metastatic disease, there was a 50% reduction of non-small cell lung cancer in patients receiving GLP-1 agonists versus the DPP-4 inhibitors. That's dramatic. Seeing a 43% reduction in breast cancer in terms of reduction of metastasis, 38% in liver and 31% in colorectal cancer. Now, why is this important? 90% of morbidity and mortality in cancer is when it spreads. So if we can slow or stop the progression to metastasis, we reduce 90% of morbidity and mortality. That is worth celebrating, whether that is a repurposed medication in the conventional camp or a repurposed medication or heck, a natural therapy in the quote-unquote integrative camp. Also, what they found here, GLP-1 receptor expression was associated with improved overall survival. So just as we target HER2s, ER, androgen receptors, EGFRs, KRAS, etc., if they're present, we'll target those. Nobody has any problems with that. But here, if GLP-1 expression is expressed, and we can target that too. Looking at breast cancer incidence reduction. Here was presented again at ASCO 2025. This is what that particular post was about. Approximately 30 to 35% lower risk of breast cancer diagnosis in patients that were overweight, obese, receiving GLP-1 agonists. That is preventative. Not only can you improve the metabolic of the individual, but it's preventative in a disease that is associated with massive morbidity and mortality. What about prostate cancer? A study out of the University of Texas, San Antonio, looking at over 120,000 men. Again, no small number. Lower incidence of prostate cancer among GLP-1 users. And in fact, this effect was larger than would be expected from weight loss alone. So showing that the GLP-1 had broad systemic support that was beyond just weight loss. There was also looking at colon cancer survivor. This was using GLP-1 agonists in patients with colon cancer and obesity, lower overall mortality, reduced sepsis, myocardial infarction, looking at colorectal cancer survival and metastasis risk also. They found here improved survival and reduced metastatic risk. Looking at 250,000 patients in colorectal cancer prevention, approximately 26 to 36% reduction in colorectal cancer incident in patients here being obese, overweight, etc. These are data points, again, abstracts. The studies to come will, I think, really show whether they bear out to the fullest fruit or whether there's major limitations there. But it shows that the potential mechanisms here of reduced insulin signaling by improving insulin resistance, reducing hyperinsulinemia, reducing insulin growth factor 1, lowering systemic inflammation, lowering interleukin-6 chronically, reducing dysfunctional tumor necrosis factor alpha, reducing obesity-associated immune dysfunction, targeting direct expressed GLP-1 GLP-1 receptors on tumors, and possibly even remodeling the tumor microenvironment. The take-home here is at least it relates into the camp of the conventional and the GLP-1 agonists, is that the evidence is starting to show that it can reduce metastatic progression after cancer diagnosis. That's the implication here. We need to see that bear out, but that's super exciting. Improved overall survival despite relative little or modest weight loss. In association with the GLP-1 receptor expression, we can target that now. And then this is consistent across multiple cancer types. And so when we're seeing a changing demographics in obesity-associated cancer, where there's a tripling in the age-adjusted mortality rates, this seems like a big deal. But Big Pharma shrill, I'm excited about this. And I'm not a Big Pharma fan. So let's flip the script. When we look at mebendazole, I want to talk about mebendazole. I want to talk about Artesunate, Artemisinin, because, when Ivermectin, I've already talked about that really ad nauseum, that all the evidence on Ivermectin is really preclinical at this point. There's one ongoing phase 1 and phase 2 trial with Ivermectin, and it still hasn't closed yet. It still hasn't reported any data yet. Of course, I talked about the Ivermectin mebendazole basically online survey. It's a good first step. We need so much more. On social media and other places, people advocate these testimonials, but they are not studies. They're not. Even if it's a case study that's written up and packaged up and sent into publication, that is one of the lowest levels of evidence. And we just have to recognize that strong evidence provides strong acknowledgement of efficacy. So when we look at Ivermectin, we're still waiting on clinical data in humans. Great first step with the McCullough group, but we need more. Is it safe? Yes. Is it without side effects? No. It works best in conjunction with other therapies. Now, mebendazole, looking at human cancer studies, there's very few. First one is high-grade glioma, phase 1, looking at mebendazole with temozolomide. And there were 24 patients here. They were using therapeutic dose up to 200 milligrams per kilogram per day. The main finding here is that the therapy was safe and feasible. Really, efficacy was not established here. Check out the show notes for the supporting evidence. The second one was advanced GI cancer. It was a phase 2A study. They looked at dose-adjusted mebendazole up to 4 grams per day. Pretty significant dose. 11 enrolled, 10 were treated. They showed no safety issues, no severe safety signal issues. All treated patients had rapid progression. The study authors concluded that this drug should not be used in the treatment as a repurposed medication in oncology outside of clinical trials. Now, interesting point there. If you just read this, you go, wow, that's it. Okay, but I want to take a segment, a quote out of the study and provide some context for that should not be used outside of clinical settings. So, quote, histologically confirmed diagnosis of squamous cell cancer or adenocarcinoma, including primary cancer of the liver, of the gastrointestinal tract, or cancer of unknown origin, measurable disease according to RECIST 1.1, defined TTP on the standard experimental treatment preceding the study, treatment with locally advanced or metastatic disease not amenable to standard treatment, i.e. progress on standard therapy or observed expected intolerance to standard therapy. Now, here they were talking about the patients that were included in the study. So now let me repeat part of that, knowing that we're talking about who was included, selected in locally advanced or metastatic disease, not amenable to standard therapy, i.e. progress on standard therapy or observe expected intolerance to standard therapy. This is the worst of the worst patients in terms of what you would expect to outcomes. How many treatments coming in could you expect to, with one thread of a lifeline, pull them back from the abyss? But that was really the context I think provides clarification. You would expect every one of these patients to progress. Why? Because there's no magic bullet in cancer care, and here they're looking for the magic bullet in cancer care with mebendazole. You're not going to find it. Could have told them pre. Second is metastatic adrenal cortical carcinoma, a case report. Here they actually found long-term disease control with mebendazole monotherapy. Now, what I have to say about this is it's a case study. What it needs to do is expand into a group of patients with the same metastatic adrenal cortical carcinoma and look and see what it looks like. Is it safe? What does it look like compared to standard of care? But here, it's super exciting. We can't discount this. This is super exciting. Now, what about metastatic colon cancer case report? This is reported tumor remission response to refractory metastatic colon cancer. Again, a case report. Same limitation as above, but evidence nonetheless. But it's evidence that can be submitted into the arena of ideas for debate and discourse, but not a testimonial. Finally, one of my favorites, you may not have heard of it, but you should start to hear more about it, Artesunate Artemisinin. Looking at Gi Hong, which a physician alchemist back in ancient antiquity in China, traditional Chinese medicine, 300 AD, he evaluated many different herbal therapies and observed them and documented them. And artemisinin was one, or it was really sweet wormwood. But fast forward to 2012, Tu Yu and her team in China, Beijing, they actually discovered that sweet wormwood, non-heated preparation, provided artemisinin, provided a great anti-malarial therapy. They won the Nobel Prize of Medicine that year, 2012. Interesting factoid here. They shared it. You know who they shared it with? They shared it with the team that discovered Ivermectin. Isn't that interesting? 2012. Who knew? But here, let's look at the evidence related to artesunate and artemisinin, because artemisinin is the direct product from sweet wormwood, but artesunate is a semi-synthetic derivative from that, a more stable, more water-soluble, but better delivered IV. So colorectal cancer, a randomized placebo-controlled pilot study, looked at oral artesunate, 200 milligrams daily for 14 days before surgery. They looked at 23 patients. What they found is that it reduced proliferation by increasing tumor apoptosis. It was an average follow-up of 42 months. And looking at the patients in the recurrent colorectal cancer group, what they found is one patient in the artesunate group actually recurred and 6 in the placebo recurred. So actually a significant difference there. But again, this was a placebo-controlled trial. So this needs to be duplicated, needs to be expanded. Finally, looking at non-small cell lung cancer, artesunate, and navalabine and cisplatin. So here, the artesunate in patients with non-small cell lung cancer was added on to the standard of care chemotherapy. They found improved disease control and a good tolerability. That's good. So this is why I say with repurposed medications are best used in conjunction with other therapies. So phase 1, metastatic breast cancer, looking at oral artesunate as an add-on therapy, showing to be safe, tolerable, and really discerning what are the pharmacokinetics of the drug. Also looking at metastatic breast cancer, long-term compassionate use, finding that it's safe up to 37 months use. That's just where they stop. No major safety concerns at 200 milligrams per day. Looking at advanced cervical cancer, 10 patients treated for 28 days. They found a reduced in expression of P53, reduced in expression of epidermal growth factor receptor, reduced in expression of Ki67. It's dramatic. Looking at intravaginal artesunate for cervical intraepithelial neoplasia, type 2, type 3, pre-cancer condition. They actually found it was safe, well tolerated, and it increased the clearance, accelerated the clearance of the HPV genotype. So, and then the last, is advanced solid tumors with IV artesunate. Phase 1 study. Love IV artesunate. Absolutely love it. 1.4 milligrams per kilogram, up to 2, maybe even a little bit higher. But comparatively here, they found that the maximum tolerated drug or toxicity dose was up to 18 milligrams per kilogram. Very safe at high doses, much beyond what's much used clinically. Now, if you look in the show notes for artesunate, artemisinin, you'll actually see that, we've got several that are out of China. Well, don't be surprised with that, because that's where the research originated as it relates to sweet wormwood, artemisinin, and yes, artesunate. So I think when we look at where things are, we are so biased in everything that's perceived. There's nobody that wants to be more natural than myself. But we have to recognize if you walk out and break a hip, we need surgery to correct that broken hip. If there's brain metastasis and you can get cerebral edema and herniation, which would lead to dramatic morbidity and obviously early mortality, if you can step in with stereotactic focal radiation, you can alleviate that and live to fight another day. Everything has its place. That's what integrative medicine's about. It's not about locking yourself into a camp and saying, well, I'm integrative, I'm natural, and so thus I will never, ever agree to use a GLP-1 agonist. Even if there's GLP-1 receptor expressed on the tumor, the patient's a type 2 diabetic and they're obese, and there's evidence to support it reduces the progression from local disease to metastatic disease. That's not a big pharma shrill. That's a person that won't allow themselves to be open to new evidence. See, there was a statement that was made during the pandemic that the science is settled. And that by its nature, that statement is unscientific. Well, that statement by that individual on X that said, big pharma shrill, that's a statement that's equal to the science is settled. Now, on the converse of that, in the conventional world, they won't even listen to or view anything related to ivermectin, mebendazole, artesunate, artemisinin. That is equal a sin, if you will, against the patient, because these therapies have been shown to be safe. These therapies preclinically have shown to be quite effective. And in fact, when you look at the hallmarks of cancer, we're now beginning to understand exactly how these therapies target the systems, the signaling pathways that pertains to the GLP-1 agonist, that pertains to ivermectin, that pertains to mebendazole, and that pertains to artesunate. So we've got to move away from camp theology. We cannot have two camps of accepted repurposed medications in oncology. What we can have is evidence-based strategies, evidence-based approaches to assessment, focus on repurposed medications, obviously they're safe. That's why they're on the market. They're being repurposed, repositioned off-label to a different treatment. But we have to understand that as the science evolves and we discover new uses for these medications, we have to be able to evaluate the limitations of the data as well as the pros of the data. And if something has significant data to support the repurposing of a GLP-1 agonist in type 2 diabetics and obese individuals, then in stage 2, stage 3 cancer, where you're trying to prevent it from progressing to stage 4, that is something that I think we need to be open to. If somebody is morbidly obese, type 2 diabetic, and they're at high risk for cancer, that is something we need to be open to turning the health risk of that individual. Because that individual is more at a high disease risk potential than they are health. But if we can turn that tide, we can turn that disease trend around for that individual. I have a good family member who has done just that. And converse, if we focus on Artesunate, Artemisinin, mebendazole, Ivermectin, we have to be willing to say that if we're using these as repurposed medications in oncology, we have to be willing to know the data and know what its limitations are. GLP-1's the same. Am I advocating as GLP-1 alone? No, not at all. Am I advocating for ivermectin, mebendazole, or artesunate alone? No, not at all. It's just saying, if we have evidence that there's high labile iron pool in a tumor, and the evidence also throughout the literature supports that tumor histologic type also likes to use that, then use artesunate. Use artesunate. And it's FDA approved, so it's been shown to be safe. But of course, it's for malaria, and of course, in the United States, we don't really have a malaria problem. So guess what, FDA, we need to evaluate this and investigate this. I would say start off by looking at prostate cancer first, just a suggestion. So let's move away from the biased camps of repurposed medications. Understand, repurposed medications serve all as the evidence guide. I just wanted to present my thoughts on this because I just found this to be very interesting. It's not a big pharma shrill. It's not a big pharma denier. It's just, what does the evidence know? What does the evidence show? Thread the needle between the two polar opposite camps and do so only with the evidence. Check out the show notes for the supporting evidence of this podcast. I'm Dr. Nathan Goodyear. We really need your help. We don't do ad buys, as I always say. We want organic growth. We want organic engagement. So drop us a question, drop us a 5-star review, and share this with those that would benefit from this, and subscribe to the podcast. I'm Dr. Nathan Goodyear, and I'll see you on the next Prescribe by Dr. Nathan Goodyear podcast.
Thanks for joining us on this episode of the Prescribe Podcast. All references supporting this episode can be found on the prescribe.com website. That's pre-scribe.com. To get your next dose of medical innovation, make sure you subscribe to Prescribe. We'll see you for your next refill.